Thank you, everybody. And I'm going to talk about 3D or 4D specific artifact. And the reason I'm talking about this is one of the main problem we are facing to make the 3D a daily clinical practice is the time we spend in deal with various artifacts. And some are widely recognized, but some are not widely recognized. So that's why I'm just focused on those artifacts which with clinical significance, but not widely recognized by 3D community. And the first one is imagination artifact. It's not from the real anatomy or function you see, but from the operator's disorientation or illusion. And let me give an example. So if you look at this newborn study of the feeding physiology and pathology, and I put the probe under the chin to visualize the tongue. Now, on this side, where's the mouse? You can see the tongue. Could you tell me, is this the tip of the tongue or this is the tip of the tongue? So if you agree this is the tip of the tongue, raise your hand. That's probably 1/3. So who agree this is the tip of the tongue here? That's about one, it's probably just 1/10. So, but for the majority of the people who probably are not very sure, but if we look at these slides here, and this slide is the sagittal section of the tongue, and this one is a coronal scan of the tongue, a section of the tongue. If you look at this movement of the sagittal plane, you can see the tongue is actually moved this way and peristaltically this way. So because no baby will suck the milk outwards, so it has to be, this is actually the tip of the tongue, this is the throat direction. So let me show here and here. So this just shows how we get used to see things. When you come up on 3D screen, you may interpret things incorrectly due to your pre-perception. Now, next artifact is we call time gap artifacts. It is caused by a long sweeping time or by the trade-off volume size for a short sweeping time. And when you're detecting a very flash event, so what's a flash event? Let me show you this. So we try to visualize the erection in the patient with erectile dysfunction. Yes, it uses University College London, and the male patients are seen by the gynecologists. So it's a little bit unusual setting. And if we see the reformatted picture here, you see not the entire pillars is visualized. But for the color Doppler, the volume is even smaller. So when we do the color Doppler scan, we got smaller volume, and the arrow shows the deep artery area. So we give the patient Viagra, you can see the difference. So before the Viagra use, you see a deep artery here, but after the use of Viagra, you can see the two deep arteries enhanced. But the problem is here, the artery enhancement only lasts a very few seconds. But we know if you do a stick sweep or other sweep, it takes at least 5, 7, or even 15 seconds. So if without using a real-time quick scan, you might just miss another part of the deep artery enhancement. You may draw a wrong conclusion, say the patient has at least one-sided artery defect, which is not the case here, we're shown here. The next one is we call wavy artifact. It's very common, everyone knows stitching artifact these days now, but wavy artifact is not widely known. But if we use basic knowledge and we inspect the right plane, which is reconstructed plane, you can actually detect the artifact. So this is a 3D stick volume. I grabbed from the 3D community. If you look at this original sweeping plane, you see very lovely concentric contraction and relaxation the other way. But if you pay attention to this coronal plane, which is reformatted, you can see on the first half, when the cursor moves down to the atrial level, you see the heart is doing this. But no atrial will do this way unless there's some large pericardial effusion. But this is supposed to be a normal heart. So that's actually caused a wavy artifact. And another example of wavy artifact is here. You can see this is a reformatted 3D or 2D picture. If you look at this reformatted view, which is a very lovely ductal view, and starting from right atrium through tricuspid valve, right ventricle, pulmonary valve, and the ductus arteriosus, and the descending aorta. You can also see the three valves here, the aortic valve in the middle, tricuspid valve in the middle, or here, and the pulmonary valve here. If I slow down, what would you see? You would think this is a normal view of the heart, reformatted from a stick volume. But if you pay attention, you see the tricuspid valve, aortic valve, and the pulmonary valve, they're all closed in the same time. How could it be? So that's because the timing correlation between the scan and the final imaging has something distorted. So that's what we call wavy artifact. But in case of wavy artifact, is it still useful? Yes. It's useful for gross structure assessment. It's useful to understand the spatial relationship between different parts of the heart. But you have to be very cautious and to commenting on the continuity of different chambers. And also, you have to be very, very careful about using this technique for reformatting the TAP-C and the MAP-C measurements. I saw many, many articles over the past several years about tape-seeing and the map-seeing using the 3D, so you have to be very careful. And it's not actually suitable for analyzing regional wall motion abnormality and not suitable for arrhythmic assessment. So whether the wavy artifact avoidable? No, because it's the fundamental problem with the technique itself. So we have to be very cautious. So what's the future? It's to improve the cardiac gating technique and also improve the 4D scan and better using the 4D real-time 3D probe, which with sufficient spatial temporal resolution and with sufficient volume. So it's what we said, you can achieve a direct volume scan without hard gating. So this is an example of the future. If you do a matrix real-time 3D, it actually doesn't matter. You move your probe during the scan, you got a no motion artifact. You may say, oh, this is an original scanning plane. But in real-time matrix probe, there's no scanning plane or reconstructed plane. Both planes are original plane. So you see this short axis view of left ventricle and the moderate band in right ventricle and pulmonary valves here. They all visualize without any distortion. But I agree we need to improve the resolution for the daily clinical use. Thank you.
Thank you very much, Jing. We have time for one question or two questions from